I'm Dr. Madeline Attridge, a GP partner in Barry with some out-of-hours experience. Today I'm going to be giving a short presentation on the management of urinary tract infections by remote consultation. So these are often seen in a face-to-face appointment, but I've often thought that this is actually an unnecessary waste of both the health professionals and the patient's time. Evidence has shown that short-term outcomes of managing suspected UTIs by telephone are the same as those managed face-to-face. And often your typical patient with a UTI is actually trying to continue working, and having to come in to see a doctor and wait in your waiting room when no exam is necessary actually seems silly. So firstly, just to recap a few key elements which I might have mentioned in previous presentations you've seen for all remote consultations. Confirm you have the correct patient. Ensure you speak to the patient before introducing yourself to avoid any breach of confidentiality. And if they're unwell, it's sometimes helpful to ensure that even if you're speaking with a relative, make sure you speak to the patient at some point. You need to make sure that you take a more thorough history than usual, because patients often need more reassurance that you've listened to them when they're speaking to you on the phone. And you also need to get more information to get an idea of how the patient actually is and if they're not that unwell. And also don't forget to safety net more than you would normally. So firstly, the guidelines for the management of UTIs are divided into those under 65 years old and those over 65 years old or catheterised. So I'm going to split each and give an example of how I'd manage a typical patient. Even in Wales, we tend to follow the flowchart from Public Health England, which I've shown a picture of, and you can easily find the link to that. The under 65-year-olds are probably one of our commonest groups for UTIs, and they have more classic symptoms. First of all, it's important to exclude things that aren't a UTI, so checking their sexual history and checking about vaginal discharge. In fact, the absence of vaginal discharge plus 2 urinary symptoms has a 90% probability of being acute cystitis, so it's quite a key feature to ask about. Excluding that this isn't sepsis or pyelonephritis, so ask about kidney pain. So I say, have you got any tenderness in the back, on the sides, under the rib? Are you aching all over, high fever, nausea, vomiting? If you do think it's possible not pyelonephritis, the patient will generally need a face-to-face appointment, unless this isn't possible. And I've discussed the management of these cases in a different presentation, which you can see on managing more extreme cases during the COVID-19 pandemic. So also check in their history that they have, whether they have anything that makes them more susceptible to complications or antibacterial resistance, such as recurrent UTIs, pregnancy, and being immunocompromised. So then, taking the history, so you first of all ask for their key symptoms. If they've got 2 of dysuria, new nocturia, or cloudy urine, then you definitely don't need to do a dipstick. You quite clearly can just treat based on that. If they only have one of those key symptoms, or if they have none of them, then ask about if they have other symptoms such as urgency, visible hematuria, frequency, suprapubic tenderness. If they have 2 of those, then you can do a dipstick test. However, you can just ask them to drop that into the surgery themselves, rather than actually to have a face-to-face appointment. Or a relative or friend can drop it off if they're at work or something and can't make it into the surgery. So using the flowchart, you're then going to treat, await culture results, and decide that a UTI is less likely as a cause, or decide that a UTI is less likely as a cause for a patient's symptoms. As part of the treatment, I always discuss self-care for the first 2 days if the symptoms are mild. This means encouraging them to drink 6 to 8 glasses of water a day, enough to avoid feeling thirsty and keep the urine pale. Sending them a copy of the RCGP target leaflet on UTIs, and you'll see that on the next page. If symptoms persist or are more severe, then they can start the antibiotics. Or in some cases, if they've already waited a few days, you're just going to start with an immediate prescription. And then you're going to safety net, of course, but we'll come on to safety netting in future. So let's look at a case. It's sometimes easier to think about cases you might actually have seen or see. So Helen is a busy 35-year-old school teacher. She presents with urinary frequency, which is causing her to get up a few times at night, and dysuria. Her symptoms are mild and have just started. She is not pregnant and has no other significant medical history. She doesn't really want to come to the GP surgery as she can't afford to take time off work to attend. So here, following the flowchart, you can confidently tell her that a UTI is likely, and testing a urine isn't going to change her management anyway, so she doesn't need a face-to-face appointment. You tell her to increase her fluids. You can text her a copy of the UTI leaflet or leave it for her with a prescription, explaining how to treat and prevent UTIs without antibiotics. But you also give her a backup prescription in case her symptoms don't improve. In another case, Becky is a 55-year-old supermarket cashier. She presents with dysuria and urgency and no other symptoms. Using the flowchart here, a dipstick test would be helpful. So she drops off her urine sample, which shows a negative nitrate and positive leukocytes. Here she may have a UTI, but it also may be other causes such as genitourinary syndrome with menopause. So you advise her that the initial management of UTI is conservative and give her advice on fluids and a target leaflet. In the meantime, send her urine sample for culture, and if she's still symptomatic in a few days and her culture is positive, then you can think about antibiotics. So it was important to note that the last flowchart was just women under 65, but the next group we're going to be discussing is all the over 65 years old and the catheterized, male and female. So the important thing in this age group is that we don't need to do dipsticks. For years, carers have been phoning me up with dipstick results, and I've been telling them that a urine dipstick isn't going to change my management at all in this group. That's because they're unreliable in this group. Up to half of those in long-term care facilities and almost all catheterised patients will have bacteria in their urine without an infection. So they will have positive dipsticks, but antibiotics will have no value. The other reason that Public Health England have segregated this group is because they have more different and slightly more vague symptoms. So again, it's important to check if they've got sort of symptoms of sepsis and pyelonephritis, which features putting them at more risk of severe or resistant infections. Consider always if symptoms could represent something else. For example, fever, delirium could also be caused by cellulitis or gastrointestinal or respiratory infections, in which case you might need a face-to-face to review that. So looking at the UTI symptoms. So let's come on to some examples for this age group. So firstly, Margaret is an 80-year-old care home resident. She presents with offensive smelling urine, and the care staff have dipped her sample, which shows nitrates and leukocytes. She has no other symptoms. Here, following the flowchart, she doesn't meet the criteria, and you can explain to the care staff to disregard urine dipsticks in this age group. However, you may advise them to increase fluids, as this may still be a sign of an early UTI or just simply concentrated urine from dehydration. Next, Beryl is a 72-year-old fairly independent lady who her family noticed she is a bit unsteady on her feet. Taking a thorough history, you also elicit that she was incontinent twice in the last 2 days, which is unusual for her. She has no other symptoms. So this is quite a common over 65-year-old presentation as well. But here you can confidently discuss how urine dipsticks won't aid in making a diagnosis. And as she has 2 symptoms, you can treat on that basis alone. So you send a urine sample for culture to confirm the diagnosis. And you also, just because she said she was a bit unsteady, you might also want to sort of follow up regarding making sure that she's safe for a falls risk and things. So lastly, so the men in the under 65 years old group, these can still be managed over the phone in the majority of cases, but you do need to make sure that they don't have any symptoms of an STD or prostatitis symptoms. So asking them, do they have any pain in the perineal area, so the area between the front and the back passage. Ask them if they've got any rectal pain or any pain in the bottom part of their tummy as well. In this patient group, dipsticks are poor at ruling out infections, so you're going a lot on symptoms still, and you always need to send a urine for microscopy and culture. So even if you're not seeing them face to face, get someone to drop that off for you. And in this group, there's no observation period. You're going to treat immediately if you suspect a UTI. And the safety net for this one particularly is that if they have a history of recurrent or relapsing, you're going to have a very low threshold to bring them in face to face for a review. if possible.